Hello, I'm Fiona Sampson from the Centre for Urgent and Emergency Care Research at the School of Health and Related Research at Sheffield University. And I'm going to talk about some of the findings from our evaluation of the online NHS 111 service. The project was funded by the NIHR HS&DR programme and was led by Jeanette Turner, who has since retired, along with colleagues Emma Knowles, Jackie Long and Jo Costa, plus a wider team. And I'd like to point out the usual disclaimer that these are our findings and do not necessarily reflect the views of the NIHR or the Department of Health and Social Care. So I'll now give you some brief background, outline the methods used and then the headline findings from the study. If you wish to skip to any of the findings, they're around 4 minutes in. We were asked to make the presentations engaging and interesting, so I decided it would be appropriate to let the computer make the design decisions for me, and I've selected design ideas in PowerPoint to see what it comes up with. And I'll talk about why I felt this was relevant at the end of the presentation. So, NHS 111 telephone service was set up to provide users with clinical assessment by telephone and direct people with low acuity, non-emergency health problems to the most appropriate urgent and emergency care service, or to provide self-care advice. Healthcare advisors, who are usually non-clinical, ask the caller to answer a number of questions following different clinical algorithms, and then provide what's called a clinical disposition or recommendation about what service to contact and the time period for doing so. So for some callers, a transfer to or a callback from an NHS clinician will also be offered. However, due to significant rise in demand for the telephone service, the NHS 111 services have struggled to meet demand and saw an increase in waiting times for urgent calls. So in 2018, in order to address this problem, NHS England rolled out the online 111 service, a digital alternative to the telephone service, which enables users to answer the initial questions using a computer, tablet or smartphone, using the same pathways algorithm that the healthcare advisors use, but using a computer or tablet. And they will similarly receive this disposition, or they can provide their own contact details and a way to call back from a clinician. And the aim was to achieve some sort of channel shift to reduce the demand for the telephone service. So when the 111 online system was piloted in 2018, the NIHR put out a call for evaluation of the new service before the national rollout. And they funded a programme of work at the University of Sheffield where we evaluated the impact of online NHS 111 on the NHS 111 telephone service and urgent care system, alongside a programme run by Cathy Pope and colleagues who undertook an ethnographic study of patient pathways and workforce implications of NHS 111 online. And they're based at the Universities of Oxford and Southampton. So the main focus of this presentation is understanding how the telephone and online services are used differently and whether there is potential for channel shift of people from the telephone to the online service. Some of the quantitative results are being presented by Richard Jakes and Rebecca Simpson elsewhere as well. So we used a mixed methods approach using a convergent design and incorporating 3 different data sources, surveys and interviews. So for pragmatic reasons, we used existing surveys that were being administered by NHS 111 sites and requested that online surveys were amended slightly to incorporate the same key data set to enable us to compare questions for the two groups. So we also spoke to a sample of 32 recent online NHS 111 users who were identified via the survey. And finally, we spoke to NHS 111 staff to understand their perspectives of how people were using the different services, given their experience of people using both services, or those who've been referred for a clinical callback. So we analysed the quantitative data first, comparing differences between online and telephone users using chi-squared test proportions and adjusting for age, sex, ethnicity and presence of long-term conditions using multinomial logistic regression. We analysed user interviews and staff interviews separately using a framework approach, focusing on how and why the different services were used and the potential for channel shift. We used a convergent design, analysing each component separately, merging the data to compare results. And we present here our key themes that help to explain whether there is potential for channel shift, with examples of the data items that contributed to our conclusions. So firstly, we found that the human interactions involved with the telephone service contributed to higher satisfaction with the telephone advice than the online service. So telephone users reported higher levels of satisfaction with the service than online users across all comparable measures, and these were significant with a p-value of smaller than 0.001 for adjusted measures. Telephone users were more likely to report that they were very satisfied with the service and very likely to recommend the NHS 111 service to family and friends, even after adjusting for age, gender, ethnicity and long-term conditions. Telephone users were more likely to rate the advice given as very helpful. And the qualitative analysis suggested that the ambiguity and oversimplification of question wording and a lack of flexibility in how the questions are answered in the online system contributed to the lower confidence in the online advice than the telephone advice, with the human interaction of the telephone call being key to extracting the most appropriate and relevant information from the user. Almost half of the users interviewed felt that the questions were poorly worded, overgeneralised and not relevant, which made them question the professionalism of the service and reduce their confidence in the advice given. So this person here said, "I had a sore throat, but I had no option to say that I'm asthmatic as well, which was the reason I am worried." And concerns about inappropriate and difficult to understand terminology were reflected by staff who reported spending more time with online referrals due to the need to re-triage users who had misunderstood questions. And the ability of health advisors to probe and to obtain what's called the softer information that would guide users down the most appropriate algorithm was seen as key to obtaining trustworthy outcomes by both users and staff. NHS 111 was felt to provide a useful adjunct to the telephone service, particularly for certain conditions. So online 111 was felt to add value to the healthcare system, and over half of users reported that they would be very likely to use the online service again, although unfortunately we did not have comparable data for the telephone users. Users valued the speed and convenience of online 111, particularly when the telephone service was busy. And this was particularly convenient for people with young children and other time pressures. So this person here says, let's say I'm looking after my son or something else is going on in my life. I get a phone call or something. I can stop NHS 111 at any time I want. I can restart it at any time I want. So I like that kind of convenience. Some users described how they initially used both services simultaneously but dropped the telephone service due to waiting times. Participants described their decision to use online 111 or the telephone service depending on the type of condition they were consulting for. So online 111 was the preference for information or advice relating to what they perceived to be simple health problems, such as stomach bugs, colds, or identifying, for example, the location of an emergency dentist, particularly when primary care services were unavailable. However, more complex or urgent problems were felt to be more suited to telephone 111, where that human interaction could help direct the user to more appropriate advice, or to intervene where necessary. So simpler, lower acuity conditions were more suited to the online service. And again, the importance of human factors in understanding the complexity of healthcare problems was highlighted as key, particularly for users with chronic conditions or with multimorbidity, as the online questioning didn't enable consideration of underlying problems that may impact on the problem being consulted about. Online NHS 111 also increased access for some users who would not otherwise use the telephone service. So whilst the lack of personal contact may lower the quality of advice, it provided access to the 111 service that people may otherwise not have had. The online service provided access for people who did not like or were unable to use the telephone due to communication difficulties, such as hearing or language, or who lacked a private space in which to talk. And the impersonal nature of the interaction also suited people who wanted to avoid human interaction due to social anxiety or due to the problem being consulted about, for example, genitourinary, sexual or mental health problems. And this member of staff said, we do understand that it might be a really good first step for seeking help for mental health problems, because you don't have to talk to somebody, you can just fill those in and then sort of cast it out and hope that somebody can help you, as opposed to ringing and having to, say out loud how you feel. We also identified that the lack of human interaction with online 111 services enabled people to use it more speculatively than they would the telephone service. So the online service was seen as just a computer, and users felt no responsibility using the online service, unlike the telephone service where they spoke to real people. They could consult about problems where they would be unwilling to bother a healthcare professional more speculatively. This was also evidenced in the survey, where they reported lower compliance with advice given, and being significantly more likely not to have contacted another service if they hadn't used 111 than the telephone users did. So the online 111 service was used as an alternative to Google and to seek reassurance. and with users placing less value on both the interaction itself and the advice given. So this one patient said, "This is more just generally concerned, but not too worried, if I can put it that way. I might use the online service, but if I had any genuine concerns, I'd probably call 111, and if I had any real concern, I'd phone 999. So before I move on to discussing some of the conclusions, I'll just highlight a few of the limitations within the methodology and interpretation of results. So firstly, due to the pragmatic use of surveys, we were constrained in some of the questions we were able to ask, and there were a subset of questions which we were unable to ask both user groups. So the user sample was limited and wasn't representative of wider users of NHS 111 online. And in particular, our sample had overrepresentation from white British older users, and that's in both the survey and the user interviews. Survey responses were low and therefore subject to responder bias. And the survey and some of the interviews took place prior to the COVID-19 pandemic, but the majority took place during the pandemic, which may have affected the findings due to the public health messaging which was asking people to use the online 111 service due to high levels of demand for the telephone service. Similarly, waiting times for the telephone service may have affected the satisfaction and the likelihood of people using it again. So moving on, in response to the question about whether the online service is likely to enable any channel shift, our findings suggested that there was evidence of some channel shift, so those people who were using the online service as it was quicker, more convenient. There was also some duplication of demand, so people using both services at the same time, but also some potential induced demand due to opening up access to a subset of users who would not previously have accessed the telephone service, as well as those who use the online service speculatively due to the lack of responsibility involved. So with the current online service, it's unlikely that significant channel shift will happen for patients with chronic conditions or multimorbidity, due to the importance of the human interactions involved and the trust that people have in the human interaction. And as you may have spotted, the PowerPoint images demonstrated that current computer algorithms can pick up some detail but struggle to deal with the nuances or some of the more complex problems that they're faced with. So thank you for listening. If you have any questions or comments, please email me. My email address is there. And if you want to read any more about the study, the full HS and DR report is available on the website here. Thank you.